We're going to hear about Ms. J. She is a 39-year-old female with a past medical history noteworthy for hypertension, dyslipidemia, new onset diabetes, and class 3 obesity. Her A1C was 6.4% over the past 2 years, but has now recently jumped to an A1C of 9.6%. She's symptomatic. She's having some polyuria and just generally doesn't feel great. She admits to enthusiastic participation in holiday food celebrations, and she's not really been reaching her activity goals in the colder months of the year this winter time. So some of the guidelines would suggest starting at least one or more medications, considering insulin therapy. I think in my training, I think like once you hit 10, with no evidence behind this to my knowledge, that's when you start talking about insulin therapy. But I guess for our patient to start, is this someone where we feel like we could maybe make a fair attempt with metformin and lifestyle changes initially before sort of becoming more aggressive? How would you manage this patient sort of out the gate who's presently not on anything?
Right. Yeah, Paul, it's a great case because there's a couple of red flags that we want to just make sure that we hone in on before we make a decision. So one is that she's young. She does have class 3 obesity, and of course, we're seeing an increase in even youth onset type 2 related to obesity. So that's not so shocking, but I would want to make sure there's a family history of diabetes just to make sure the story makes sense, because we're seeing even type 1 diabetes or autoimmune type of diabetes that progresses to insulin deficiency pretty rapidly. We're seeing that in adults more than we used to. So in fact, 50% of what we used to call juvenile diabetes, which is type 1, happens in people over the age of 18. So, and actually, I think that's moving to more like 25. So I would just make sure we're not missing that. And then she also reports that she's polyuric and she doesn't feel well. So instead of thinking about that magic number where we start insulin, it's better to just listen to the patient. And she's telling you she doesn't feel good, and that's not a good sign. A lot of patients, as you know, they have an A1C of 9 and they feel fine. And actually, that's the biggest problem in diabetes. So she's reaching out to you for help, and I think we have to get to the bottom of her potential insulin deficiency. So what I would probably do is be thinking about treating her for sure. And you could always start a therapy, get some blood tests, which I'd like to talk about, and then see her back quickly, because I don't think anything that you do today is going to make or break the situation. You do have a little time to figure out what the best course is. What do you think so far? Does that make sense?
Yeah, because this happens a lot, because nowadays almost every patient I'm seeing in internal medicine, overweight or obesity, is getting an annual A1C. So we have a lot of data on people, and you can see where it's been 6 months or 12 months, and all of a sudden they just jump, where like their A1C goes from, pre-diabetes range 6 to 6.4, and now it's like, like this one, 9.6, or sometimes even the low teens. And the patients are really hesitant to start anything beyond like metformin in those cases. So that's why I like this question. So what sort of investigation are you doing here?
I wouldn't make it a big deal, but I would check for antibodies. And it's only because we see the rise in this problem of autoimmune diabetes. So I would check. It's called GAD65, or glutamic acid decarboxylase 65. It's just the most prevalent islet cell antibody that we see in autoimmune diabetes. So I would do that, get it out of the way, make sure we're not missing that. And then you could also check a C-peptide and a glucose level. I would say, it's not necessary unless you see the patient's not responding to your next step. But I would get the antibody. Now, how would I treat her? I would want to treat her with something potent, because she, as you're saying, she's sort of falling off the cliff, as sometimes we say. This is actually something that is well described. It's similar to heart failure, actually. We talk about the Starling curve. I don't know if you guys remember that.
Sure.
But you push that failing heart with more fluid and salt retention, and then at one point it's sort of, you fall off the curve, and the dynamics don't allow for compensation anymore. Same thing happens with diabetes in the beta cells. So we see it in type 2 diabetes and in type 1. So this sort of dramatic rise in the A1C, we see it. It's classic type 2, but sometimes in a young person, we don't want to miss type 1 diabetes hiding under the cloak of type 2. So I'm going to say GLP-1 receptor agonist is in this patient's future if she is who we think she is, which is somebody who has type 2 diabetes, probably familial. She had prediabetes for a few years, so it's probably quite classic. And she's going to need something potent because she's just quite hyperglycemic.
Before we move past, can I ask this, sort of seeing the later presentation of type 1 diabetes, is it an increase in prevalence or just an increase in recognition that's happening, or some combination of those two things?
Oh, it's a great question. I think it is both, because we saw in the 90s, all of a sudden the prevalence of diabetes ticked up rapidly. And that definitely because our definition changed and detection changed. There was sort of more process measures all of a sudden coming out from insurance companies to monitor for diabetes with blood glucose, at least at the time. And nowadays, we know we can use A1C. So I think it's both. But now, in the last 10 years, it's really true rise in prevalence rather than just increased detection. That's at least what we think. But I think it's a combination of both.
So let's recap. The red flags from this case would be like, because she's young, if she didn't have a family history, that would be a little suspicious. The class 3 obesity makes it a reasonable story, but the fact that she's sick here is what's making you want to be more aggressive about the initial therapy, because you do see a lot of patients who, if their A1C tips over a little bit or jumps from 6 to 8 or 6 to 9, and they're just like, they're not feeling sick, you can start them on metformin. And if their lifestyle is terrible and they really clean up the lifestyle, I've seen a lot of those patients just go right back down to the pre-diabetes range with metformin. But what you're saying in this case, what made you think because she's feeling sick, you might be more aggressive and start more than one agent up front?
Yeah.
Tell us how the conversation would go here, or what you would think. What were you thinking for initial therapy here?
Yeah, that's great. So I would basically explain to her that I'm concerned she doesn't feel well, and but I do think this is likely progression of what she had before, which was prediabetes. And I would go over quick things that she might be doing that are getting in her way. So juice drinking, soda drinking, milk drinking are the big ones. If she's suddenly going crazy with that stuff, maybe it's a really big factor. But otherwise, if there's nothing really clearly identifiable, for example, let me just add this, a steroid injection into a joint. Just make sure we're not missing those things. But if we don't have something super identifiable, yes, I would move her to a GLP-1, and I would explain to her that because her A1C is so high, we want to get her under control. She's young. She's going to benefit from that really rapid control and weight loss, because the guidelines now sort of say let's focus on weight loss and glucose control at the same time for all patients with obesity and diabetes. And then it's such a potent agent. It's similar in potency to insulin, and it'll give her so much more in terms of benefits. So I think I would move there quickly. Now I would get those lab tests, and if she does have some concern for insulin deficiency, I would bring her back in and make sure that we do start insulin. But again, that's a small percentage, but don't want to miss it.